Hello, and welcome to this episode of Spotlight on Policy. In this second part of our discussion about healthcare reform, we continue our discussion with Dr. Jim Girvan and Dr. Sarah Toevs from Boise State University's College of Health Sciences. In this episode, we talk about the public option or the role of governmental programs in the U.S. healthcare system. Do we have elements of public healthcare in the United States?
Yes, we do. I'm always interested in the term socialism. I hear in the media and certainly at some of the town hall meetings, okay, we're becoming a socialist country. You don't want to become a socialist country. Well, the fact of the matter is that, first of all, having a healthcare system that is, let's say, publicly funded, okay, is in fact a social program, but it does not make a country socialist. And the countries that have that type of system in terms of healthcare are not at all socialist countries. They're very free market countries with businesses. Now, we do have, as you say, social programs. Medicare. And Medicare, once you turn 65 in this country, you're in Medicare. I mean, you have to enroll, but if you don't enroll, there are penalties and so on. So, I mean, that is, in fact, a social program. You don't do anything in the sense of you're in it once you're 65. We also have Medicaid program, which is a social program for particularly for low-income women and children. We have the Children's Health Insurance Program for children who are in a family where their family's income does not qualify them for Medicaid. It's above Medicaid, but they still can't afford health insurance. And so that's an example. We certainly also have the VA, the Veterans Administration, all right, which probably actually is the Cadillac of our social systems. It's great. It's integrated. It's got the lowest administrative costs and all of that. We have the system in our armed forces. We have the system for all government employees. All of those would be social programs that pick up the cost of health care. Some certainly have co-pays and all of that, but nevertheless, they're largely social programs that I hear some people railing against. Oh my goodness, we don't want social programs. We have all kinds of social programs. As a matter of fact, the public piece of healthcare spending in the United States today is about 45 or 46%. So of all of the healthcare spending in the United States today, 45 to 46% is from these types of programs, and then so slightly less than half. I might add that some of that cost that I'm quoting here, the 45 or 46%, includes the fact that if an employer provides health insurance for an employee, that in fact is tax deductible, or in other words, it's not considered income, and so that offset of taxes is also considered part of that 45 or 46%, about 4 or 5% of it.
Okay. So.
One of the common features of the public systems in the U.S., Medicare, Medicaid, the VA system, the Children's Health Insurance System, is that those represent single-payer approaches to delivering health care. All of the expenditures that occur through those programs are paid by the federal government. So we have, one of the components of a public system is that it is paid by one single entity, which has some dramatic impacts on the whole paperwork, processing, management of those programs. And that's where we actually see the most significant savings, is that having a single payer system, the provider doesn't have to have can have simplified record keeping, billing procedures in place because the rules are all the same, as opposed to having to submit paperwork to a multiple of different insurance providers.
So to wrap back there, the single payer would be the government in that case.
Mm-hmm.
For example, the federal government to pay for the VA,
Mm-hmm.
any costs at the VA. The provider means the doctor or the hospital or the lab that
Right.
does the health care provision. Okay. All right. So would you say then that Canada's system is a single payer? Because the government pays through the provincial governments?
Canada's system is a single payer. It's actually, I mean, it's taxes collected by the government, but then basically flowed through to the provincial level. So the provinces in Canada kind of set up their plans, but nevertheless, absolutely. And most nations that have high market economies have elements, at least, of single payer. Other than the U.S., although, as you can see, we have quite a few programs that in fact are single payer.
In fact, in terms of what you're saying, we're halfway there.
We're close to halfway there. I again, it's an interesting, at some of the town hall meetings when there was happened to be a 70-year-old person, and I understand the angst and so on with all of this. I mean, change is really hard, but was saying, boy, we got to keep the government out of health care, and yet the person's on Medicare. Said, well, gee, I don't want the government to fool around with my Medicare. Well, you know what? Medicare's 100% government. So again, it was kind of a misunderstanding of the source of funds. The other piece of that is when we talk about government, we are the government. I think that gets lost sometimes when people say, oh, gee, let the government do it, or we don't want the government to do it. I mean, the government is us. The government, the revenue of the government is our tax dollars. So anyway, that's I think that sometimes that escapes people. So.
Well, obviously a complicated set of issues. I appreciate your background on this. I think we have a little better understanding of how our system does it in the current configuration. You've been listening to Spotlight on Policy. This is the first in our series on healthcare and healthcare reform in the United States. I was joined today by Dr. Jim Girvan, Dean of the College of Health Sciences, and Dr. Sarah Toevs, the Director of our Center of Aging here at Boise State University. Join us next time for our next issue of Spotlight on Policy.